Okay, do you want to get started?
Yeah, we have everyone. Yeah, that's fine. Yes.
So hi, everybody. We figured we would meet with the providers, like we said, at last week's meeting, so that we could really start to go through all of the information that's been provided at the work group meetings so far, review some of the issues and concerns that have been brought forward, and see if we can start to come up with any kinds of recommendations that we can put toward the report that we're supposed to submit to the Public Health Committee by January 1. So I kind of culled through our meetings to date and pulled out, you know, information based on everybody's feedback, and I shared that list that I sent with you. Um, I shared it with Sasa first. Um, and we just thought, okay, let's get it out there. Let's see. I'm sure you have plenty of other things that you might want to recommend or edit, but at least to use that list of issues and concerns and any kind of potential recommendations that were voiced. Um, let's see if we can use that as foundation or starting point and then go from there. I have had some separate calls with some of you where um been questioning the law itself, 2419, and exactly what it requires us to do. Um, so Sasa and I didn't really have this conversation because I just had a conversation today that I think is important to bring forward. Um, the law itself is something that as of October 1st, most of the areas within the law were required to follow, but are there things within that law? Are we interpreting it all in the same way, implementing it all in a similar way? And are there things in there that we really are struggling with that we think we may need to also make recommendations? One of the things we called out during the meetings was like the judicial branch lookup, the crime report being general to town. But the other pieces, the data collection that we're required or says shall collect data. Um, those are other things that I think we need to make sure that we're considering when we think about any recommendations. Sasi, you want to add anything before we
Yeah,
start?
so I agree looking at the current law, looking at the areas where there's gaps, right? Where as home care providers or home health providers, we can recognize the gaps and realize that it's not even included in some of the legislative language. Um, Tapping into what we are used to doing every day, but also looking at things that we've never had as options in home health, right? So it's good to look up the backgrounds. We're going to do the check in criminal records and all of those things. I think it was evident in the meetings to date that even with that, we're still not able to capture the information if someone's a juvenile, if they are from out of state. So I'm not sure that that's, you know, the best solution right now as far as leaving it there. Looking at some of the current practices that we use to educate our home health colleagues and staff, just broadening our thinking and being open to realize that if we're going to just go by the criminal, if we're going to have buttons and GPS and all of that, how can we also have that column for people to get the care that they deserve when they have controversial diagnosis or backgrounds?
Sorry, I'm taking some notes. Does anybody have anything that they'd like to address out of the gate? Do you want me to bring the law up on the screen? The issues and concerns, the recommendations. I just want to know how you want to proceed because we need to really try to work through probably quite a bit of information today.
So Tracy, the checking the criminal histories and the registries and all that is like, to me, it's almost semantics because, we're just checking something. We're not getting an actual report. And where I always find our challenge here is the referral sources that we're getting information from, they're not disclosing things to us. And sometimes I wonder what the reason is for that. If they're scared we're not going to take the referral, or do they truly not know the information? But I do feel that sometimes there's not the disclosure that we truly need. And I do feel like sometimes there is intentional withholding of information. And I feel like it's putting us at a disadvantage because we can only go by what we're seeing, and what we find, but there's just not good transparency. And I don't know if there's anything we can do to kind of, hold those referral sources accountable. We're putting a lot of eggs in our basket, or we've had a lot placed in our basket. But what else is being done from the system, looking at the system to support this? So we're not the only healthcare providers out there. So why aren't these other healthcare providers held to the same types of standards?
Can I add to that, Jen? I agree with what you just said 100%. I think it's like where is the information available? What is the expectation from providers? What does the law require slash expect? And I'm sure there are many, but there are at least three sort of big buckets of potential information sources. One significant one is the referral source. One is, and we've spent a fair amount of time in these meetings on sort of what's available on different websites and what does that mean from an individual provider perspective, and what are you supposed to do in terms of searching, recording, right, documenting, and what do you do with it? And then the third, of course, is the client and the family itself, which we all do, but it's a lot, right? And then it's challenging. You're going to have holes on this side. You might get some information here, but it might not be complete. And I think it is challenging to sort of implement and operationalize the expectation of the law, when really, obviously, what you're trying to do is provide safe care in the home. But I didn't help anything. I'm just adding, I guess, or agreeing with what you're saying. There are a lot of challenges, I think.
I guess I just wanted to add into that in addition to finding it hard to collect the information, at some level, I think that there's a requirement that we tell people we're investigating them and get their permission. I don't think it's okay to just start investigating relatives of people without their permission. And I actually, early in the process of SB1, talked to Marty Looney about it, and he agreed with that, at some level, you can't just say, I'm investigating the whole family, and if you don't, without telling them. And once you get out of Connecticut, you don't have the same access. You don't know whose brother's going to show up from North Carolina and whose child's going to show up from England, and you can't check all that. And then what are you doing? Are you discriminating and you're only checking the people who live in Connecticut and missing all the other people? So it just seems to me the whole thing is wildly impractical. And I agree about the quality of the disclosure. And when I was thinking about this morning, I was thinking, this is kind of like saying it's dangerous for kids to cross streets. And if you had a kid and you didn't want them to cross the street, would you say to them, you may never, ever cross the street? Or when they got to some point, would you say, let me teach you how to cross the street safely? In other words, in that maybe our focus should be on how do people keep themselves safe as opposed to what is our obligation to do it for them, given limited resources and limited availability of information.
You know, Barbara, the last meeting that we had, where the local police spoke, they really focused on that a lot. You know, the importance of training, situational awareness, how to protect yourself. Those are the things that we can have some control over. You know, we are obligated by OSHA to provide a safe work environment, to have a plan in place. So, but we're not obligated based on OSHA to look up all those reports.
Right.
And we've already, I think, made it very clear, and many agencies who are doing this on a daily basis now can prove that it's not working.
Yeah, there's a number of challenges, and I think even the OSHA issue is an interesting one because while they don't tell you what you should be looking up, if you don't, when there is when something happens, they're going to say, well, you didn't do all these things that you should have been doing to provide a safe work environment. And I think the whole nature of our working environments, as we've said over and over, is by its very nature unpredictable. Every time a staff member goes out to any sort of residence, wherever someone is living, you don't know who and what is behind that door, or if there's a working fire alarm, or if, you know, all of these things. So we've got a number of, I think we have a number of issues. I think, you know, I think the positives are that we are identifying potential issues now before a staff goes out. We are finding that there are, you know, through the limited scope of the judicial and sex offender registry checks that we're required to run, you know, we are identifying possible concerns with individuals who either are going to require additional safety services present, or we might not be able to see those people. And we also said, you know, and I think we made it very clear through the process of this legislation that this would be an unintended effect of not only slowing down referrals and in the intake process, but what, you know, what I refer to as sort of an indirect discrimination of individuals based on where they live or their history. And,
Yeah, which
you know,
is what
whether,
Sasa was saying.
yeah, you know, and whether those individuals, you know, what their rights are as an individual to certain types of care is also something that, you know, I can't define, but I'm sure that the legal world has a standard of how those individuals, you know, what obligations they're entitled to, whether it's our services or another healthcare entities. But this, you know, we kind of saw this coming. You know, we saw that it's going to be a shift of, well, if we don't take care of these individuals and keep the cost of care to the system lower, they're going to end up utilizing more expensive public resources. So.
And Chris, I have to, go back to how you said, if we miss something and no fault of our own, what will happen, and I don't mean to pick on DPH, but it always comes down onto the agency, and the agency is held liable for so many things where we could never control the entire situation. We never know what we're walking into. And instead of working very closely together, which we're trying to do here, it's punitive always.
It is. And OSHA's response was the same. It was very much coming in with the tragedy saying, you know, how you didn't provide a safe work environment. And that's, you know, but then they're not defining how do we do that?
But what did they say about in Cromwell, although different, very different in the nursing home?
Yeah.
But, of course, we don't know I mean, if anybody knows more of the cases, it's probably Tracy, but you can't speak to it. But we don't know the entire situation with Cromwell. Were there red flags that this elderly man was going to do this? Thank God it was only his wife. Not only, but you know what I mean. didn't include other individuals, but now is Apple in all kinds of trouble when they may have had no idea that this type of event would occur? And instead, again, it's punitive.
Yeah. Lauren,
So both sides of the coin. The law that is passed, we're not being asked to um, protect against every scenario. Like if somebody were to come from out of state and visit, or you had a neighbor over, my understanding, please correct me, Tracy, if I'm wrong, but that we're doing our due diligence to try to keep our clinicians safe in the home. So by checking the patient's name on the sex offender list, the Connecticut websites and things like that, and then looking at that two ways, I think of a patient that I had prior to working at this agency. And when these things were not in place, I was asked to case manage a patient. I went into the home. It was in a state of disarray. I didn't feel safe. Something did not feel right. Later, we found out that the primary caregiver and all of the other children were convicted murderers and on probation. So that would have been an example of like that would have helped me because I didn't feel safe in the home and those things came out later. And then I know I gave the example of one of my clinicians this past year because we did our due diligence with running the name of the other residents in the home on the sex offender website. We found that this patient's son was a convicted rapist and had abducted and repeatedly beat and raped this woman. So then I knew I need my clinician to have an escort with her. And thank God I did that because without that information, when she went to the admission, she would have been alone with that man who was convicted of the crime and a patient who was demented and bedbound. So, like, just to play both sides of the coin, I don't think we're ever going to be able to say with 100% certainty this house is safe because something can always happen. But I think they're trying to have us do the best that we can in that scenario. And I also recognize being at Yale, we have much greater resources than perhaps some other agencies are. But I know like we're starting this at intake, running these names, and then we're also combing through all the available epic notes and materials that we have looking for any high risk red flags, so that if somebody came from another place, okay, we're trying to do our due diligence to make sure up this isn't something, there's a history of violence in this home or things like that. But like even doing all of that, a situation I ran into 2 weeks ago, we did everything we were supposed to per our safety protocol. The patient's home we thought was safe. My clinician went out and the patient's spouse, who has significant dementia, was having violent outbursts. So then we had to have a meeting and get escorts in place. So, there's no way to predict everything. But
And
I think
that's right.
we're being asked to try our best.
Yeah, agreed.
Lauren, I just want to, thank you for pointing out the availability of resources that you have, with your system.
Hmm.
With our system, I mean, I literally have one intake nurse.
That's really hard.
She's a department of one. And I have one clinical manager for home health, one clinical manager for hospice, and myself. That's it. So she's the one, I mean, our intake nurse is doing all of this. We're helping her to the best
Right.
of our ability. And, and then you talk about the availability of escorts. There is no such thing as an escort service for visits out here in the Northeast corner.
Okay.
So I tried to apply for the grant to maybe partner with our organization security team so they could, staff us in off hours and if we needed escorts. And I didn't receive any of that grant funding. I
Mm.
received a very minimal amount that won't even cover the cost of our buttons that they're going to wear. So
It's
that's a
tough.
huge thing. It's a huge
Right.
burden for us. And,
Right.
and when my poor intake nurse, she's, asking these questions of referral sources and she's getting beat over the head,
Mm.
and that might sound dramatic, but she is really, it's such an uphill battle. And it really, for agencies like myself, we're a small agency, it's not the same as, a
Absolutely.
healthcare system like Yale or Hartford. Not, no offense to any of you who have the resources, not just in, technology and finances, but in people as well. So we just don't have that here.
So Jen, I definitely love that information. Lauren, can I ask you, the individuals that are doing the research, or so to speak,
Hmm.
I mean, that for Yale's home care, that's a big home care. There's several different facilities or agencies or,
Offices, yeah.
offices. Thank you. I mean, that's got to be a full-time job for one or two people.
The intake director has been charged with that, and they have now put into protocols in place so that every single intake nurse who processes that referral is having to go through each step of the safety protocol to ensure those boxes are checked.
Wow. Now, are you doing it for your hospice also,
Yes,
in
every
addition to?
yes, every single patient that is coming onto home care services across the Yale system has to have this procedure done before we will take them on.
Wow,
Mhm.
wow, that's a lot.
It is.
So
And with
I
late
think that,
referrals, you must lose some patient referrals then too.
They've gotten it down, I have to say, to be pretty timely, but I
is put
fully
in place.
recognize that I have resources that other people on this call may not. I fully
Yeah.
Right.
recognize that.
Yeah, you said that, yeah.
Yeah, and their policies are going beyond what's in the law. So,
Yeah, and I guess that was my kind of my point. I just, of caution that it, whatever we ask for, make sure that we all can do it.
Hmm.
yeah,
Yeah,
Because
funding.
there's no way I could achieve what
right,
Yale is achieving.
right.
I wanted to tap on something around the current legislation. There seems to be some confusion to me between the scope, the legal scope of home health and what we actually can deliver versus what's asked. For example, when we talk about the assessment and some of these risk assessment tools that we're considering, right, to decide. So once you do the background check, or once someone might have any kind of history of violence, maybe they have a paraphilic disorder, whatever they're coming to the table with, when we're asking registered nurses, which that's primarily who we have starting a case or overseeing other registered nurses within home health agencies, I'm not sure if the commitment to do this risk assessment, am I going to be safe when I go into care for someone, is aligning with the competence of what a registered nurse going in to do an open. And we're talking about someone who, once you get to these disorders that are managed normally by a team of people in the Department of Corrections, managed by a team of people at the IOL or White Forensics or ACT teams, when we send one registered nurse in, who then might be followed by LPNs, and sometimes even an aide with a Q60 plan of care if that's needed. And we're saying that as a home care agency, we're admitting this person because we're in the business of admitting people, and we're going to commit to deliver care. I think what we're seeing is, though we've been committing to do that, there's a group of people out there that, based on DOC and what we've heard from the police department and what we've heard from the other ACT teams, that require a certain level of competence and requires a certain level of a team approach, that we are sending registered nurses in to go on in and manage alone, solo, and be able to pick up on the subtle clues and changes that someone's changing. As a visiting nurse, I remember going into homes and let's say someone's gonna hoard, or let's say they have OCD where they're gonna go around and collect things in the community or, repeat their behaviors. You never notice when the home becomes so cluttered that you're now squeezing your way through the room. You're not necessarily seeing it because you get to know someone over time. That clinical practice might decline and you might not pick up on the subtle clues that there's a crisis in the home. So I'm wondering if we can think outside the box and go, do we need more support in home health than the traditional model of a registered nurse goes out while waiting 2 weeks on a physician, right, to give us orders or wherever might be needed. And we're the only ones sometimes that's seen someone for days and weeks after they've left a hospital while they're during that in between. And sometimes we do this for a while. They go to their physicians every 3 months. They're declining. We need ACT teams. We need support, and we're not getting it. But we don't have the competence always to recognize that we're really committing to doing something twice a day, every day. And this requires an entire team. That's what I'm wondering as far as the folks with those behavioral health disorders that might result in violence, right? We know the folks with the cognitive decline, the medical diagnosis, those go through CHN, and we know that they might do things in the home, but someone who might actually decline and get to the point where it's just one behavioral health nurse in the home. What real support is needed there? And that's my thinking around that. How can we broaden the scope? Because right now, a registered nurse, what we're asking them to do in a home, it doesn't even match the scope of DPH. And checking the background and getting it. Then what? We're going to send the same registered nurse with the same background and clinical skills to manage this person. And that's where I'm reviewing this legislation over and over and wondering, is it just us that can go in a home and manage a case over 60 days realistically for long term going forward? Is that the model? And during the last meeting, when I asked about EMS, I asked because I don't know where EMS can say, whoa, we got this 911 call. Someone might be in cardiac failure or something's going on, but let us do the background check before we deliver life-saving care if that's what's needed in that home. And we're implementing that in home health. And it's a similar thing. One nurse is showing up, and now we're making this decision. Let's check the background quickly on everyone in the home before we deliver that care. We're not doing that in hospitals. We're not doing that with EMS. There's other disciplines that's going in a home. And are we going to start to tell EMS, hey, you better check that background before that ambulance pulls up and you walk in that home? Or are we going to send them together with someone else, fire and the police and everyone else?
You asked that question though, Sasa, and wasn't it, was it Barbara Cass that said, 911 activates either the police or fire to go with EMS automatically?
Yeah, I
Yeah.
think that's
So
right.
case
And
in point.
I think that's why you see them show up whenever, you call for an ambulance. Police are usually first on site.
Yeah, yeah.
So that would make sense. Sasa, those are really interesting points. The EMS, aspect of it is certainly an interesting one. They have supports that we don't have because of how they're being dispatched. I think regarding the risk assessment, I think the idea and concept is just to be better prepared. It's not that we're going to make our nurses the expert at reading every situation, but I think it's two things. One, just knowing something more than we do before we walk through the door. And two, hopefully providing them with some additional training so that they have some insight, like, I know we're repeating it every 6 months now. We're doing literally because, if you're not in that situation every day, you don't have an opportunity to experience and sort of practice those skill sets and reinforce them. I really like your idea, though, of maybe broadening the scope of supports in the home. And one thought that came to mind was, and we've discussed this with different insurance companies who want to pilot different social determinants of health with social workers and other sorts of clinicians. If there was reimbursement for that, that could be another aspect where we look at maybe incorporating those individuals who are really good at dealing with difficult situations, and they're trained in that, and they've got years of experience in that the nurse doesn't necessarily have. The nurse might be really great at identifying that there's a change of condition, or that maybe the patient's not responding to these meds, or they're not taking them. But if it escalates, or if there's something else going on that we just need to monitor, to your point, to make sure we're not becoming sort of numb to the situation that individual is living in, it might be nice to, operate in a larger and have the financial support from the state to operate in that.
I agree. I had this conversation with Tracy the last time we spoke, that when we call our nurses case managers, oftentimes, this is the PCN, the primary case manager, as since I've been doing home care, it's the longest, and you're told these things are required for you to have this patient on services, right? If they can't get to the physician, if you need medications refilled, if you needed to go pick it up, all the things that we do in the middle, including calling a mobile crisis team, sit in, because now we're told to wait on mobile crisis. You sit there, and then when mobile crisis gets there, you need to still stay, right? None of that is reimbursable. But I guess that's a different conversation. But we're doing so much just to keep someone home and to keep the pieces together. And that's because it's a thing about nursing. We are committed, right? We are committed to what we do. We're voted the most honest profession year after year. That's what we do. We're committed, and we lost Joyce and Willimantic. We also lost an aide in East Lyme, and that aide died in a fire, well, as a result of a fire. And when you compare what's happening here, is you're having a group of people that's so dedicated to doing their job day in and day out and taking care of people, that we're losing our life along the way. That's what I see here. And yeah, we're going to do the background checks. There's all of that stuff. But then somewhere out there, there could be an aide, right? Or a nurse in home health doing a shift, doing shift work. And there may not be a smoke detector, and that person may be on a ventilator. What are we going to tell those individuals? Are we saying to them, leave, call 911? So there's education needed around that. And I don't want that to get lost in the shuffle, that we lost another person in home health to a fire also. And it is a concern. I heard earlier of the hospice team and oxygen in the home. And we know that people who smoke end up on hospice. People with poor judgment end up on hospice. People with stoves in their home end up on hospice. What are we doing to protect everyone in home care? And yes, our paraphilic disorders, our folks with violence, the community issues, that's all there. But I want to include everyone as we move forward. And then also, Senate Bill 1 said that our task is to ensure that the residents of Connecticut are safe. And I will keep reiterating, those residents also include the people who require care, the people who live in the communities, in the buildings and such with these individuals who require care, and it includes us and our colleagues. So we have a task ahead of us, but it includes all residents or people residing in the state of Connecticut. So how do we move forward with do we like this criminal background checking thing? And we have to be honest and say the thing that might not be status quo or uncomfortable. Are we okay with having to run the criminal history on every single person we care for and everyone in the home? Or is that now an obstacle? Is it benefiting? Who is it benefiting and who might it truly harm along the way? And does it prevent injury all the time, most of the time? Because once we know, then what?
That's the broad brush approach to law too. You know, because it happened, now you have to do a criminal background check on everybody that you're going to see. And the law does not require that we look up all of the people who are in and out of the home. And it doesn't require that we do the sex offender registry of the neighborhood or the building, you know. It just requires that patient. Now, it's short-sighted because we know, you know, that it could be many more people other than the patient that we should be concerned about. But again, I guess it goes back to the law, and is it appropriate even to have to do that part, or is it more appropriate for us to be able to, because of the level um, of job that we do, whether it be the nurse or the aide or the social worker, whoever goes into that home, should we just have access to information about risk and not have it be at the responsibility of the agency, but some way of getting information so we can at least look at risk? We talked at the meetings also about having a risk tool, a standard risk tool that has a standard validated scale that might guide us. But again, for funding, look at what happened. You know, Jen talked about the funding, the grant funding, but the grant funding was only for Medicaid, nobody else. So nobody else has any risk. That's discrimination in and of itself.
It's just very short-sighted.
Mm.
Really is.
So I think we understand, right? We understand what what the challenges are, but I think we also have to try to fight for the fact that we're home health and hospice agencies and we're not law enforcement. And although the first set of laws now exempt hospice, the work group was tasked with looking at both home health and hospice. So I think we have to come up with some recommendations, but we have to be cautious not to
Make it harder on ourselves.
make it harder. Yep. In fact, I think we've already found problems with the current.
Tracy, this might be crazy or me just being extremely optimistic. But is there, a way for us to say we're happy to enact doing some of these things, but there has to be funding from the state for an agency making this or less, So for those smaller agencies, it provides them with the financial resources to have somebody who could do that, an intake or an escort for when that's needed and things like that. Is that something we could request? That may just be me being really optimistic.
Yeah.
Okay.
I think, but part of this group's task, right, is to decide what do we need and how do we want it to operate. And I think, it might be good. I know you had suggested looking, sort of going through the law just in the interest of time and saying, let's look at these pieces and, decide what we like and what we don't like, and maybe what we need to change, because it's a couple of parts, right? The first part is all about this intake screening, which we've been talking about, and the identifying, all the aspects about the patient or the client, as they refer to it, and the location, right? So what are the crime stats? is it safe, from hazardous materials and fire alarms and whatnot, and just decide what's reasonable in this and what's not, and are there, because again, our task, right, is to make recommendations back on, on what do we need to support this and what might need to change.
But also recognizing that we have the OSHA general duty clause, that although it's wide open and you can make your policies whatever you feel best protects your staff on any given day, something can happen. So you're not going to be able to prevent everything, but having good practices in place and training, train your staff, get out if there's a question. So-
Tracy, when you say train your staff to get out, it brought me back to recently with a mock survey that we had, and there's a fire in the house. Yeah, and what are you supposed to do? And, they say you're on a plane, oxygen first, right, for yourself.
Mhm.
But I was told, no, you have to, a bed-bound patient, take the bed-bound patient, try to put blankets under them, drag them out of the bed, drag them out of the house. Not likely an easy task for, some hospice patients, perhaps a lot easier than some regular medical home care, just due to size, but will probably hurt them in the interim there of removing. But it's true, when are you safe? When do you stay, or when do you say it's okay to leave? And again, it comes back to then what are you held responsible for? EMTs, you're taught right away. Is the scene safe? That's the very first thing you do. And you allegedly don't enter if the scene's not safe. We don't know that. And a lot of EMTs don't know either, but at that point until they enter the home. But just something to think about.
And I agree with you. And then you throw in some of the issues that the staff face, right? Especially out of fear of losing their jobs. Can you imagine a fire is happening and you ran outside and you left your patient and then you have to call the agency? Let's say nothing happened. You have to call and say the EMTs came and found me, or the firemen, they found me outside. And this is how you, based on what Stephen said, the portion of people who work in home care that deal with their own social determinants of health and can't make ends meet. Can you imagine the stress of knowing that this is it? You're either at this job and perfect and keeping it, or you're not gonna have your next meal. So imagine being in a home where something isn't safe as an aide, a nurse, wherever, but you need this concept of, I need this job and I need my caseload. We have to now look at how does that concept in home care put our staff in a predicament where they're staying by any means, because it means I get to have a schedule tomorrow. If I'm per diem versus salaried, how does it affect me being able to just step outside or call in to say this home isn't safe, if that's their everything? It's how they keep the light on. And we have to start to look at that as leaders, right? As CEOs, as entrepreneurs, as whatever role you might play in the leadership at your agency, realize that there's another side to this. There's a group of people who they're clinging to their caseload. And that also puts some safety concerns up, right? And it's to let them know it's okay to say something when you see something, support is coming, you're not less than, you're not the weaker person on the staff, and you don't have to go through the snowstorm, and you don't have to slip and slide all over ice just because you needed to earn a living that day. So all of that we have to look at, and how it affects the safety of our team and how it affects the community and the image of home care, right? The image of home care that sometimes got portrayed and lost in the shuffle was that we're just sometimes out doing whatever. So how do we change that image, especially for the behavioral health nurses? The concept sometimes is it's not a real skill. It's a med admin. A med admin visit is actually a skill. We're going in and we're giving someone medication that they need in order to remain safe, right? And not become psychotic at times. But the concept is it's just a med admin nurse. They're going in, they're popping in and out. We can reimburse them less. We can give them a bigger caseload. It's just a quick med admin. It's never just a quick med admin. So I think a lot of what we do here, we're gonna have to advocate for change on all levels, advocate for the image of home health, and that we're doing something big. We're doing something big and we're keeping people home.
Sasa, I think you bring up a really good point about leadership and our role in our clinicians and how safe they feel to report to us when they're uncomfortable. So you have to create these trusting, safe relationships where they feel like they can come to you and say, this is uncomfortable, or things like that. Or I go over with my staff. If you're uncomfortable in a visit, you don't say that you're leaving. I need something from the car to do this. You go out the door, you get in the car, you leave, you call me. I think we as leaders do take a big responsibility here and allowing our staff to feel safe and advocating for them also to get, safety classes on, how to be prepared and what to look for.
So the law includes the training, and I don't know how everybody else feels, but I'm kind of comfortable with how it's outlined because it does give broad um, allowances to agencies to create their own training, to bring training into an agency, to establish the training protocols in whatever way you want to. If you feel that we should recommend as a group that there's a particular training that needs to be had, then we can put that forward, but I caution people to do that. There's a lot out there that is really good training. So I think the law addresses that. It also addresses what you were just talking about regarding giving an avenue to your staff to report. I mean, I don't like the language of it, and we had to get the language clarified, but those check-ins with your staff, at least on a monthly basis, gives you the avenue. I mean, we may want to make a recommendation to change that. I don't know, but I think those two areas at least offer. And we're talking about how training is probably the most important thing to train your staff on how to recognize problems and what to do.
Mm-hmm.
And then checking in with your staff so they have an avenue to be able to report.
Yeah, I do like, I'm okay with that portion of it as well. And, we opted to do like an anonymous survey. And we've had really good outcomes with it. We've been getting lots of responses, and people are putting their concerns, maybe not leaving their name, but then what we're doing is I made something up called a safetygram. It's like a newsletter, and I put the comments in and then suggested, here's what you could do. What about this? What about that? And, the response has been very positive from the staff. So I mean, I think that portion of it is okay.
And for us, sharing of best practices like that can really help all of us learn other ways of doing things and to optimize the training piece, I think.
Yeah.
But I don't think it's anything we want written in the law.
Right.
Right.
Yeah, I know there are some facilities that I've read research about that conduct peer-led safety committees and the influence that someone can have. Like, so you find that nurse or that aide or PCA that's a leader in the group. And the difference when you keep these town hall meetings within the agency where it's peer-led and you actually don't have the highest level of leadership in the room, and how much more you hear, how much more people will express when they feel like they're in a safe space to do so, and then actually feel as if someone's going to go back and, you know, advocate for this change on our level down here, and then you actually see some changes happen. And I think those are some great ways, with also the, you know, the anonymous surveys, but just to make sure that while we do the quantitative side of things, we do the qualitative side so people can feel embraced and not alone. And I think those are some great ways also. Yeah, so thanks for that, Jen.
Do you think that this group should put forward a list of best practices to consider,
that'd be
but
good.
certainly not for any law,
Right. I think
but
how you phrased it, best practice, is really good.
Yeah.
Yeah.
Yeah, guidance could work, right? Where
suggestions? I mean, to me, I was worried about, if we're a legislatively appointed work group and we're making any recommendations, if we intend them to be best practices and not law, we have to be cautious.
Agreed.
Mhm.
Agreed. Because even without the clarification that was read regarding these monthly safety assessments, it's pretty vague. And, when DPH comes in to do a licensure review or a complaint or something, they're gonna have an avenue now, another avenue to say, well, what's gonna be their expectation of this? And what are they gonna want to see? And I like your idea, Jen, of doing it as an anonymous survey to sort of maybe open up general feedback. We don't do it that way. We do it where it's, sent out and responses are recorded with the individual, because I'm worried also of proving that we send it to our direct care staff. It becomes now I'm worried. Well, what is DPH going to say when they come in? And, did you send this to, 100 people every month? It gets tricky. So I think I like the idea of best practices. I think Tracy would have to be very careful on how we present that, though. And, it might be good to focus on some of these aspects of what they're asking us to do now, back on the screenings, and look at those pieces. We heard a lot from the law enforcement about the systems that they have and the access to these systems. And I think when we started this group, many of us spoke of sort of the high level challenges or wants or needs that we might see. And I think this was a pretty common one, having some sort of system. If this is going to be the law, well, it is the law, it's going to continue to be the law that we have to run sorts of checks to make sure that we're able to provide the services as we have historically in an efficient and timely manner and respond to the referral sources, then we need to have access to the data, easy access. So intake can run it, or an individual designated in any organization could run it, but we need a way to have access to this sort of general screening info, which, as we talked a little bit about today, just gives us a picture of what we might be walking into and what sort of hazards there might be, and how we might need to prepare for that. So we're not sending a nurse out or a therapist out blind to potentially a really bad situation.
So I think, Tracy, I think I saw in your notes something about, a common depository of
Repository, yeah.
information. So the safety device, that we're hoping we're piloting right now. One of the features of it is it does like a visit evaluation based on address. So the clinician, when they're there, rates the visit from like a 1 to a 3. 1 is safe, 2 is meh, 3 is I don't feel safe at all. And then it makes like a dashboard of like locales based on address that clinicians don't feel safe or feel safe. And we'll be able to pull that up and look, within our region where our hotspots are. But maybe something like that, like on a statewide basis.
So it's subjective.
But it's from the people who are actually doing the
Yeah.
visits.
Yeah, no,
And
understood.
it's based on address. It's not, there's no patient name there. It's just address. And we had the Plainfield police here doing some education about drugs and paraphernalia in the home. And I ran that by them and they said, that's an excellent idea. And it's very similar to what, on a simplified level to what they use. Because, their advice was, and kind of what we heard in the presentations over the last couple of meetings was, yeah, just call us and we'll tell you where those hotspots are. So this is a way for us to do it ourselves. So could we, like, as providers through the state, have like a statewide something of that nature? I mean, the technology's there. If we could, harness that somehow.
What device are you piloting right now, Jen?
The Katana. It's part of
Yeah.
Lauren,
their, like, it's
has
one of
Yale
their,
pulled anything out, Lauren?
I'm sorry, has Yale?
Rolled out any safety devices yet?
Uh, They tried a button on the ID badges, but I was told that it did not go well, so they are not rolling it out and looking at using a different device.
A lot of agencies have tried a lot of different devices and each agency seems to be a little different, Karen, as
Yeah.
far as what seems to work with their staff and what doesn't, or what's in a price point. It's a lot of different things.
Yeah. Are you
Um,
finding one more
but
common that people like?
I think that if we make the recommendation about some type of a repository that would give us regional hotspot areas, then the question, I don't think we should be tasked with this, but the question becomes funding.
Mhm.
And the question also becomes, what do the statutes say as far as you and your role and your agency licensure? What do you legally have the ability to access for information? So the police have readily available information because they're law enforcement.
Right.
So are the statutes going to tell us we cannot have that information, but we can call? And of course, that means, okay, if I asked each one of you how many of you serve a certain town and 5 of you would raise your hands right now. So all 5 of you are going to call the local police. It's just a lot of legwork.
Right.
So I would think that if there's some way of, and, granted, it's antiquated systems in different towns depending, but you would think that there's some way that all that information can go to one common database.
And we heard that these different law enforcement divisions and agencies have it. They have it for the town. They know the areas. They have an ability to flag things by address. They've got all this information. And I agree with you,
But
Teresa.
it's something that
Yeah.
can go up to one.
I think that's the right approach because then it's fair for everybody. Everybody gets access to that. It's all in one place. There's going to be overlap right now. We can go out and see a patient and observe an unsafe situation. And let's just say it's a congregate living facility of some sort. And Sasa's agency can come in after us an hour later, seeing another patient in the same facility, and she has no idea of the danger that one of our staff just witnessed. So I think, the ability to somehow share, we don't have a system to do that now. We have no way to communicate that. And to share that information that really could be life-saving, or prevent them from walking into a situation that, otherwise they would have no way to know, and vice versa. So I think if there's some way we can, if we have to continue to run these checks and whatnot, we should be able to share more global information. And there's enough of these security, panic sort of buttons out there now that you think, is there a way we can utilize some of that? As we have looked with different vendors, we're talking about that too. Is this a way we can share information with other people that use this system? Is there, so I think you're right, though. It has to roll up somehow to a central repository.
I do think there are some challenges with individual agencies being the reporters of some of this stuff because everybody evaluates things so differently. It could negatively impact access to care in a way that is unintended. And I mean, I guess when I saw your repository note, I was thinking, and I guess I just misread it, is there a way to sort of bring together all the publicly available things that are already out there for us to check as opposed to us recreating something? Even though I
Yes.
understand the benefit of that, I also think there could be some real challenges with implementation or creation. Whereas these other things, I know they don't all speak to each other, but they already exist, right? They're just in
Right.
a
The
bunch of different places.
repository I think that we were talking about was really what exists already through state police, local police, those databases,
Correct.
not us creating our own, but asking the state to give us access to those databases.
Right.
But then how each agency interprets that information again goes to the subjectivity, but that also goes to how each of you run your own agencies anyway. You have your own policies and procedures and decisions, decision making based on how you want to run your business.
Correct. No, and I think Terry, you made a great point. Things are always going to be subjective, and it depends on the individual. Some individuals might not be comfortable in a situation, others may have no issue in that same situation. So it just depends. I guess my point was just taking that because Tracy, I think the note you sent out was pretty clear. It was just taking all those pieces that we're currently required to, and I think that's at a base level what we're looking at. And I'm just thinking a little bigger. So, well, what if we expanded on that? Say, what if this system also included some sort of stats, based on, agencies that are out there, or staff that are out there, because it is challenging, and I think the other piece of that is sharing the medical information. So if we get a referral, we take referrals from Yale, we take referrals from Hartford, we've got all these referrals coming in, we're not getting the whole picture, right? I think that's the other piece of this. We need to ask for a broadened scope perhaps of not just home health, but home health hospice, and include somehow the referral sources to have a responsibility also to share this information. Because we can ask for it and they can say no, but now we've just wasted a whole lot of, administrative time and resources to the system, and we've slowed it down. So.
Thanks, Chris. It almost feels to echo what Tracy is saying about the police and what they do. Pull you over, let me check your background. I want to know what you've done or didn't do and where you should end up based on what I read, right? Is there a warrant for your arrest? Are you good to go? You have a license? You're good to keep driving. I'm towing your car. It almost feels as if we're saying in order to receive home care services, the individuals who need it, You now need the responsibility, the patient's rights and responsibilities. It's like we're shifting it to your responsibility and someone who might already lack access to care because their background is such that they've been getting discriminated against since probably before they were even born. Their mother got discriminated against, their grandmother, her. So let's look at the cycle here. And what we're saying is at the moment that someone accepted care, they're willing to participate in their treatment planning. Now, here's the thing that you're going to need to do. You're going to need to do all of these things, and we're going to sit in front of you. We printed out the form. It's like 2 pages worth of information we're going to get. If we don't get it from the hospital or whoever, we're adding this additional responsibility to people who need care, lacked access to care before we got called, will continue to lack access to care once we deny them when we see the background, because I know that's what most agencies are going to do. So I'm looking at the public health implications here when we're adding this additional role to individuals who are in need of care, truly in need. They could be dying, need hospice, whatever, just got told you have 6 months to live, and we're going to do this extra piece. We found out that you may have been arrested a minute ago and you're a level 3 or a level 2. So then now what? Because I don't know of a hospice agency that I know of, right? That's here and an extension of DOC in the community. So we are that DOC hospice. So what's going to happen? And when we add this additional burden on individuals who need care, and if I was a patient who relied on home care, an individual who relied on home care, and I'm watching all of this and I'm listening, I'm not sure I would feel as if I wouldn't have too much hope, especially if I lived in certain communities. So when we get this big data haven, right, that's not required in any other arena to deliver services, then what? I think this is the big part that I want to get to as a nurse practitioner, as a provider. Then what? Who's making what decisions for the people who rely on our services? I think I want to get to that part. I would love to know, once we see it, and this is what's happening, if we're really going to go there with this, what's next, right? This committee is not about resources, so we can't talk about the resources, right? We can't go down that avenue.
But we
So
can mention it.
right, we can mention it. So the individuals in the congregate settings, the halfway homes and such, chances are there's more than one, and that's our lowest reimbursement rate. It's a subsequent, it's the lowest reimbursement rate, but we're doing this high risk care. What's the plan once we get the data and we know of this controversial background? What's the plan, right? At Harriet, we know that we're overstaffing. We're overstaffing to make sure that when anyone comes through as a referral and the hospital tells us, they're telling us, right? And we're looking up who's at this address potentially, right? What's gonna happen? How do we curate this care? Right? It's kind of like we're now concierge home care people. How do you curate this care to this individual with this additional burden on them to get care? So we now have to overstaff, and we're overstaffed, and knowing that sometimes we're going to need someone else to go out with a nurse. And is that person clinical too? Is that person just someone that we're going to consider an extra person to go out? Is this a CNA? Who would that second person be? Because I know patients who or individuals who could take down 2 people. I've seen on psych units where it takes 13 people when a code is called to get one person to a place where they are safe, right? So when we get this information, is it 2? Is it 3? Is it 1? How as
Is it
agents?
armed? Is it?
Are they armed? And when we
Yeah.
and when we talk about a button, for 10 seconds, I just want to go there. When we tell a nurse that we are now giving them a button that's tracked, we now know where you're going and when you're going. Have we even asked them about their rights to be followed around all day with this GPS monitoring and buttons to press? What if they leave the button, the badge or whatever in a patient's home and a child presses it? Are we again going to swoop in, and who's swooping in? If they're home and press it by accident, do they leave it in the car? How do we make sure these privacy concerns are covered? And then when you do press the button and management is saying, we now will know where to find you because it doesn't take that long. So press a button and we're going to come and find you. Who are we finding? What are we finding? And what condition would that nurse be in after pressing that button and waiting 2, 3, 5, 10 minutes? So we have some serious gaps in the language, it being enforced as law, and what's really happening in home care. And then the big piece of the room that we're not discussing is the resources to do all of this and to do it in a way that is really going to mitigate risk and not create more issues in the long run.
Lauren, you've had your hand up.
So when Sas is saying what next, I think the next step is you have to determine whether an escort is going to go or not. I think with the passing of this law, and I know resources for certain people are limited, but I don't see how any agency is going to be able to enact these things without an escort, unless you're just going to say, we can't accept you. I'm not saying whether that's right or wrong, but you have to have an escort for certain situations. And then those escorts may be armed or unarmed, and that you'd have to go through the policy that that agency has when you enact somebody who's armed or unarmed. If somebody's going in wearing a button, I think that's a great safety feature for like the what ifs. But if there's a safety concern identified in the home, that person should be out with an escort, not relying on a button.
So that brings it right back maybe to when we're talking about resources that we're not supposed to
Right.
be talking about. Um, bringing back the add-on. Because this grant funding is short-term.
Mhm.
Tracy, I have a couple things also regarding what Sasa was speaking to. Um, our community, our country is focusing so much on diversity, equity, and inclusion. And one of the things that Sasa is referring to is we are already underserving, and I'll speak for hospice, underserving some areas in hospice of individuals that should be receiving support. And for whatever reasons, our agencies or our hospices agencies aren't out there. Latino is an underserved, African, Black, Brown, they're underserved. And sometimes it's cultural on reasons why they may or may not be. But with this being enacted, we really can be pushing even more individuals and not abiding by the diversity, equity, inclusion. Regarding the button, we don't know what condition someone would be in, but it's more than what we have right at this moment. That I don't know the details of poor Joyce Grayson, but had she had something, again, no details known by myself, is there a chance that had she pressed the button, would she still be injured perhaps? Or maybe she would not have been dead had she had a button. I don't know. So there's that something that's giving people a possibility of. And then I'll be honest about escorts. When I did VNA South Central years ago, it got to the point where I would not call my escort because I had to work around the escort. And you don't have time to work around the escort schedule, or you don't have the time to wait for that cop that is at another, incident somewhere because you're on to, there's a change in condition in hospice, there's other patient that needs you, there's so many variables. And I did, when I was VNA of South Central, I got to the point where when I was in Bridgeport in a specific area, I learned I'm going at 7 o'clock in the morning because many of those individuals were just going to bed and I was at less risk. Because I didn't want to wait for the escort. So these are things that we have to really be realistic about also. Just a couple points there on that.
And I think the resources unfortunately can't be avoided because even as you described, Ceci, you're sending 2 people. Other agencies are doing similar things. That's not sustainable because you're not getting the reimbursement for it. So you're not going to, you can only do that for so long. And then that will have to end, which will then mean that you don't service those patients because you won't be able to stay in business and do it. So, it's a little bit of a catch-22 to say, well, we've got, the resources are essential to us providing these services in a safe manner if this is, if this is the way we're going to do it, and we're going to look at running these things and trying to somehow gauge risk, and you determine you need somebody else because 2 people is better than 1 in almost any scenario. We need the ability to do that. And with subsequent visit types, it's impossible, let alone just the regular medication administration visit type. So there's not enough to send 2 people out if you have 2 people to send.
So just to tack on to that, so there are 2 places in which we have to make a trade-off. Fewer people are going to get served because if we send 2 people at a time, we're going to serve half as many people. And fewer people are going to get served because if we get reimbursed for 1, we're going to go out of business and nobody's going to get served. And asking for the state to fund this isn't going to work. I mean, I hired a community health worker as soon as they passed a law that it would be funded for Medicaid patients, and they don't even have the rules done yet. It's 2 years later. I mean, we're not going to get funded. Let's not make that assumption. Let's just make the assumption that they have to decide, okay, if we send more people, will we fix the problem? Which I don't necessarily think we will. We're certainly not going to fix it if somebody has a weapon. It's just 2 people are going to get hurt instead of 1. But also, people are not going to get served. So that it's a very cut and dried trade-off. And that assumes, as I said early on, that we can even do it. In other words, we
Right.
could send 2 people and they could still have a brother from Canada that, had a weapon that we didn't report. And, we're also, the worst time I've had since I've gotten here with an unhappy patient was somebody after death because we didn't get there to pronounce in time. And we didn't get there to pronounce because he was screaming at the nurse and she was afraid to go. So, in other words, what are we going to do after? In other words, it just doesn't, we can't, we don't know. Like when Lauren said, well, you can't do anything about the person visiting from next door. When you're dealing at the very end of life, you do know there are going to be people in the house. So if you're going to pronounce, those people are highly volatile, grieving, and present.
Mhm.
Do you think, I love the points that we're all making, and I think it's a necessary conversation that was so needed in home care, right? We really need this conversation. It's the truth, right? It's the truth. If we're gonna come up with risk assessment tools, and we're gonna look at the potential for violence, right? A lethality assessment, a violent assessment, who then should we tap into to help us come up with this? Who would be the experts in the state to say to us, hey, the person that have substance use and a psychiatric disorder, okay, that's someone we'll need an algorithm for. The person with so it almost seems as if, yes, we're gonna do all of the background checks and we're gonna report, but who will we turn to help us come up with the algorithm? So it's almost as if we need to look towards that next if we're gonna come up with these risk assessment. How will we get there, and which are we going to look at certain? I noticed in the Senate Bill 1, they put individuals with substance use. So we're supposed to collect if there's a substance use disorder. I'm not sure if it's the thought that substance use and psychiatric, I'm not sure why we're doing that. I don't know how the Mental Health Parity Act,
And are they sober now?
like what, so it's almost who will be the expert to tell us, right? Here's how it's going to go. Similar to during COVID, you tested positive, you're out of work 3 days, you're out of work 5 days. It's almost like we're going to need guidance from individuals who specialize in that kind of prediction to tell us. And it's not just legal people who police departments and DOC folks, but we actually need maybe those forensic psychologists and different people from with that background. Because once again, our scope in home care and the providers who work for home care agencies simply don't have the ability to do that assessment. It's not within our scope at the moment to make that prediction or to do that. So I think we're going to need to think about who those stakeholders in this state will be to help us with that guidance if we're going to look at backgrounds and make these decisions. I think that's needed as far as a next step and another cushion for
Well, what do you think about somebody like Carolyn?
Carolyn, that's an option.
Or we've got LMHA represented on the stakeholder group, Mobile Crisis. Maybe we look at them and DOC and we suggest that we have a risk assessment tool created. But I want to. This is so hard. It's so hard.
Tracy, if they're going to create a risk assessment for us, can you guys hear me?
Because
Oh, I just,
I just don't, I know I broke up for a minute, right? I believe strongly that we need to really look at the law and make recommendations for change because it's not right that we're doing background checks on 100% of the referrals coming to us. It's just not, it's not appropriate.
Yeah, I mean, how or why is it fair that we should know? I don't know. It's not appropriate, I think, also for us and for
I mean,
them.
I stole candy from the candy store when I was little, you know?
Gracie
Am
will
I
that.
gonna, I don't know. Um, But I do think a risk assessment tool, I want to go back to what you said, Sasa, when you were talking about the background checks and stuff. And if we do get that, database in heaven here that we're talking about, what do we do with that? I want to ask you a question back because I just said, I think how it's written in the law is just wrong. If they refuse to change the fact that we need to do some kind of a check, I think our only opportunity is to get it done for us than to have us having to do it. But back to what you were saying, were you also insinuating that it shouldn't be part of the law at all?
I don't see how it should be if we cannot do it for juveniles, individuals not from this state. And what does it prove? How far back should their record matter? Should it matter if it was 20 years ago? We're making it's
Assumptions.
discriminatory also. It feels
Yes.
as if it feels wrong.
Yeah, I think that's where, some sort of risk stratification tool or decision tree matrix and grid can come into play. Because you're right, you have to look at the whole picture. And then you talked about this a little bit earlier. We don't specialize in reading, criminal backgrounds off the judicial website and what does that mean and was it pled down and and then we heard that many things aren't on those websites, so we're getting incomplete information. So we need help, we need assistance with this. I really like the idea of letting someone else run it, because you're going to have probably privacy issues, access issues. There might be some legal reasons why we can't have access to those same databases that the law enforcement have. And if that's the case, then we need some method so that we can, quickly continue to run through these backgrounds, and maybe someone else gets the info and they give us a report with some sort of objective ranking scale based
Number, yeah,
on the
yeah.
factors. So then we can, some agencies or hospital systems have done this as well, where they've come up with a sort of a numbering system of, based on the whole picture, everything that they have available to them. It might be more clinical, or it might be a combination of those things, but I think you need to include it all. And maybe that's not something that we should be doing.
That's pie in the sky, I think, but it's a
Well,
good
that's
idea.
how I think.
Karen,
And when we're looking at these background checks, if we think about it, we have HIPAA in the healthcare field. We can't look at a patient unless we're involved in that patient. You have people that can monitor those EMRs. I mean, to me, I always tell people when we're getting Epic access, there's an Epic police, do not touch any patient unless they're a patient of ours. So now we'll have access to information. Someone could have murdered someone many years ago, done their time, and this is going to be preconceived notion from anybody who walks in that door. It's that individual will be treated somewhat differently. And then who's going to police this and make sure that we are not Jane Doe, Nurse Nancy's not just going into finding out about this patient or just anyone in particular that's not even a patient. Now, often, you have that gut instinct. You're like, nah, something's not right, but you pay attention, but you have to have, substantial information when you really are going to discharge for a cause or anything. But I think there's legal issues just across the board with this. We're going to come across legal problem after legal problem, and these patients and or families are going to come after somebody or some agencies for this. I mean, we have freedom of information often. Am I supposed to do it? Not always, not necessarily, but I'm like, not right. Something's wrong. I'll Google someone and I'm like, oh, has a history of such and such. Then it's on my radar. Yep, I was correct. But what's happening in every moment, and we just have to be aware. I think we're going to hit legal issue after, we really are going to have some problems.
How about this? Who's going to protect our staff when we turn down Karen because she's got a record and we won't take care of her mother and she gets furious and shows up at our doorstep? I mean, this is just one of those things that although we all agree it's a problem, training our people situationally and practically is going to do at least no harm and some amount of good. Anything else we do is going to do more harm than good. And Karen is right when she said before, whatever goes wrong is going to be our fault, according to DPH.
yeah,
I
and
agree.
OSHA,
And OSHA.
Yeah,
and
I-
OSHA.
it's a huge weight to lift.
Yeah, I don't want to leave
being
that.
in there. We don't have, I mean, the board that I had to sit on to become a nurse practitioner to be able to do that side of things. As a RN, I did not have that ability. I did not, and I can be honest. So to compare the two, it's taken us outside of our scope, and it's
Mhm.
legally, we just can't. So it's someone else's role, right, to have this done. And I don't know if it's that everyone that might potentially need home care or wants We know this, and there's the Kirlons and the CHNs that at some point there's an assessment done, and that's all there. And when we go into Provider Connect and we're asking for auth if needed or whatever, we can see these things just like how we can see if they're Medicare A, B, C, or whatever. But a registered nurse, LPN or CNA, it's not within their scope, and they're reporting to another RN.
And we're absolutely going to discriminate. In fact, that was the other argument that Marty Looney really honed in on, as I said that, think about it, most seniors who need hospice care have downsized into cities. And, you know, when I talked to Rosa DeLauro about this, I said, we wouldn't have been able to take care of your mother. You live right near Yale. It's a high crime district. We would have had to investigate you and Stan. I mean, at some point, you just have to start laughing. But the truth is, even you know, the good places people live are not in neighborhoods that we can send people without offering them, you know, other services. So there's just no way to make this law not discriminate against people, because we're going to start, nurses are going to make their own judgment, like Karen saying she goes out at, you know, 6 at night or 6 in the morning or whatever. People are going to say, well, look, downtown New Haven on the corner of Whitney and Grove is not bad, but the corner of X and Y is bad, and so I'm not going to go there. And then CMS is going to come after us.
And you're going to have certain nurses that will do it and not others, and some will use that
Yes.
as a way to not cover patients in general. You know, definitely nurses can be manipulative.
I
Yeah.
already thought of that. If I were running late and I were an aide, I could say, I don't feel comfortable going there. I need an escort. So, you know, by the time you find me an escort, I'm on time.
Another,
you
another concern I have, since we're in a second chance world, right? We're in a world where people deserve a chance. And oftentimes the workforce that's being hired, they're getting a second chance.
Mm-hmm.
So the people going into homes and doing certain jobs, they're getting a second chance. A second chance. But we're not using that same concept when it comes to the individuals that's getting care. Now, I agree, the right person should deliver the right care at the right time, right? That is a part that, I mean, maybe that should be added to the 5 rights or the 6 rights or wherever we're at now with rights. But we have to pair people with the right person also. That's a part of it. And so if we're saying and we're telling the state we're committed to delivering care, I think that what they want to hear from us also is that we're going to be willing to commit to the highest level of care, willing to be accountable, and willing to peer people. Once we know there's a risk, or a doctor or someone relate to us that there might be a risk, or a nurse go in and say, you know what, this person, and it's not a gender thing. It's not a gender thing, because we've seen situations where you might think back in the day, we would say, send a male to that house. It's not a gender thing. It's a putting the right caregiver with the right patient, right? So we have to look at even that. It's not a gender thing. It's not a send a male nurse, because I've heard that as a solution too. If someone has a paraphilic disorder and they are at risk of harming someone, they gain pleasure from harming someone. It doesn't matter to then say we're going to send a male and put our male staff at risk or in predicaments where they have to fight their way out of a home and then look at losing their license and explaining how did this occur. So I think what we're all saying is that we're leaning with compassion, but we're putting safety first, is what I'm hearing. So we're holding up safety. We're being healthcare providers and we're delivering compassion, but we want to be able to do it and have the trust of the state to do it the right way, reduce the risk, report the risk, communicate a little better. But at the same time, if someone is making a decision, this disorder, it's not good enough to just have care started right away. This disorder, yep, you can get care right away. Who should make that decision? Because we don't have the background or the scope per DPH to make
Well,
that.
and that is why, Sasa, that DPH put section 3, subsection 3 in section 1. That was their language, that you can't deny care solely based on whatever the language is.
Yes, I saw
So
that.
I think, we're already at 4:07 and we've had a lot of really good discussion, but we really do need to come up with some recommendations that we're going to be bringing forward to the larger group for their thoughts too, obviously. But are we saying that number one and foremost is the training? I think we've all agreed that making sure that training remains a priority and training on how to recognize challenges, how to keep your staff safe, how to, remove yourself from a difficult situation. That should be there. But are we recommending maybe that we remove the criminal background check, the sex offender registry, all those checks? Are we I mean, what are we, the intake collection is very detailed on what we're collecting now. Those were questions that many of us asked in the past as well. And, Jen started the meeting today with saying that, a lot of that information is either intentionally not provided or not known. So what are we
I,
thinking we want to recommend? Are we recommending also to have some type of a risk tool? I mean, if there's no wiggle room on doing some type of a check, I like Chris's idea of doing the check and having it feed into just a number that we get. This is a 5. The DOC talked about 4s
Yeah.
and 5s versus 1s and 2s. At least that tells us about violence level. But what do we do?
Who
Escorts?
gives us that number? Where does that number come from?
Well, that's what I'm saying. It would be a
Yeah.
number given by the results of the
Law enforcement
database.
or some law enforcement
Search.
agency or this repository, because yeah, DPH, as you pointed out, has that statement that we may not refuse, but where's the protection to the agency too? Because as we've heard and as we've seen, there is no legal protection for the agency. We have the state agencies, federal agencies that are very punitive in nature, unfortunately, when it comes to any sort of incident. And so I think that's, in my opinion, starkly absent from this also, because if you're going to hold us to all these standards, you also have to assist us with that process and provide us a little bit of protection to say, well, we can't, because we all testified, we all said that this was going to happen with discrimination. We've all talked about it, and however you want to describe it, but you're going to end up having individuals who this will no longer be able to receive service because either we can't afford to do it or we're just not able to because we don't even have access to an escort, you know. And if we make that decision, as one agency makes that decision, what's the likelihood that the next 4 are going to say the same thing? It's pretty high. So I
I think
don't
we
know
have
that
an
we can
impossible
remove it.
task.
It really is. It's a really, I think, we're trying to respond to a tragedy and saying, well, how can we prevent that? That was the intent of this. Unfortunately, I think trying to work through this really quickly and get it through legislation left us with a very difficult situation in which we have learned through this work group and the law enforcement agencies that we don't have complete information. We're missing a lot. There's a lot of things that aren't there. We haven't even discussed, what are these people even in a protected class? If you want to go that far from the legal perspective, not from how we treat them, but from the legal world, do they have a right to those certain? Yeah, I don't know. This is very challenging, I think. But I think the training, I think the check-ins, some sort of assessment where you are sort of checking in with people is appropriate. safety and training curriculum. These are all good things. I agree with you, Barbara. I think those are the best positive things that we can do as agencies. If there are resources that are distributed indiscriminately, regardless of the sort of population, because if the intent is truly to protect the industry and not just the industry serving a certain population of payer, it should be across the board, for whether you want to provide these devices to your staff, provide escorts to the staff. I think we can ask for maybe reducing the amount of information. Maybe first is, we don't have the ability to collect it now. What we're getting is very incomplete. If a law enforcement agency is not, if they can't come up with another system where we can sort of feed them the information, they give us a risk score. That way it's objective for everybody and it's the same for everybody. And to Sasa's point, we're not having to try to determine, well, what is that score? You still have to decide what are you going to do with it, but at least we're all getting the same score. And we're not trying to decide, well, Chris thinks it's this way and Lauren thinks it's that way. And Barbara thinks it's this way. It would be the same number for all of us, for a particular patient and situation.
Why don't we do what they would do and answer the question we want to answer instead of the question they asked and say, why don't you, the state, set up a training program that you think will protect people better than what they're being protected now and require it for licensure of nurses, nurses, LPNs, aides. And the burden's on them to provide the training.
That's creative. I like it.
That way we can't be blamed. In other words, if we have to set up our own training program, as you pointed out, OSHA will say we didn't do the right training, we didn't do enough training. So let them decide how much training. They just waived nurses' license fees, right? So instead of license fees, they can get trained. I think we should make a very strong statement that we all went into this profession to take care of people who needed us, and that we have to consider that and our ability to provide services, because we don't want to be the only state in the country that can't offer home hospice care or home health care because of restrictions on, what we have to do. And there's no practical way that we can collect what they want us to collect, or any assurance that what they asked us to collect will prevent a problem.
Agreed.
I mean, how many people who, we have problems with are people that would never show up on any screening. If I send Chris into a level 4 home and he gets hurt, am I off the hook because they were rated a safe home?
No, you're not.
No. And
In other words, why don't we put it back in the state and say, make up a rule about what you think people should know to protect themselves, set up an agency to train it. You can have the state police do it, or you can use other people or whatever, and require that in order to renew your license, anybody who does care in a home has to take that course.
Yeah, that would force them to take some ownership in, issues as they occur.
And pay for it.
It's still going to fall on the agency, unfortunately, regardless when something happens, but at least it's a way for us to, share some of that liability.
Right, but it's going to
Make
fall
them
on us
take
either
ownership.
way. Even if whether we take on the burden or not, something that goes wrong, as Karen pointed out about that nursing home, it's going to fall back on us.
Yeah.
So I have a question as we, because once again, if we're saying, and if the perception at times is that home health, no walls, we're just freely doing whatever, moving through, if someone's going in to do a wound, an ostomy, we're saying that, oh, we have wound and ostomy nurses and they're certified to do so. And we make sure that we recruit accordingly. We make sure that we audit those records accordingly. We do all of those things. If someone's at risk of a pressure ulcer, We do all of these things. Flu season, pneumonia, we're saying, hey, we're asking these questions on the Oasis, and then we're making sure that we close those gaps. And if we are hiring people, we make sure that they did all the backgrounds, did they take a TB test, did they do all of these things? We do the background check. If we have a task, and I'm just wondering if we're considered right now as some leaders in this space, right? And I know that it's a big task, and I do believe that we're up for it. I can hear it in each of us, right? I think we can come up with a solution to look at the fact that we've been, for the most part, delivering home care services for years. Some of you before me, right? And I've been doing this for almost 30 years. And pat on the back, we've been doing a really good job. And we did that through the pandemic. We kept people home. We helped to decompress hospitals and wherever. And we did this. I believe that as a committee, we can do this too. And we can ensure that the community understands that we take it seriously. We are going to change the way we do some things, the guidance that Tracy is suggesting, or the language, right? The guidance, or a new approach to looking up some things, right? I don't know who put in there. We need to know if someone's been a victim of domestic abuse. I don't know their thinking. I'd love to ask, and I probably will revert back to Senator Anwar and Rep. Vehi. What's the rationale? Because we might not know it. I want to know a little bit more information. Why do you believe someone who experienced domestic abuse is on the list to not get care until we know that information? Why, if they've abused substances, and which substance, right? Why? I get the smoke alarm, I get the smoke detector. That's stuff we can see. It's pretty clear. It's black and white. But what I want to know is the rationale. And Tracy, I don't know if it's worth exploring that, but I want to know the rationale. The person who said these list of things are what we need to know. I get it.
Senator Marks.
Yeah, so I'm gonna probably ask her, but the person who harmed a healthcare worker in the past, okay, now that's a red flag. I want to know, because the list is long. Right? I think the list is long, and part of it is what we're saying. The list is there, great. It mitigates the risk. The button mitigates, or it reduces the risk, right? The education reduce the risk, but will never 100% prevent something from happening. So we're reducing risk, but does the list need to be
What it
this
is.
long?
Yeah.
So let's evaluate the list. If they want us to do some checks, we do checks when we can, and we document when we can't, just like a skin assessment. I was not able to turn this person over today and check their back because they're 500 pounds and I couldn't do it, or patient refused. So if we have a list, with which we've had lists, we have a 16-page OASIS document that we do, we get what we can get, but does the list really need to be that long? And is everything relevant to the lethality or the risk of violence? So I think it's something that we should hear. I don't know if it's possible to have the conversation with Senator Marks, you're saying may have created this list, just to
Oh, I'm
find
guessing she drove that conversation.
out. It's so
But
maybe, sorry, Tracy,
I'm
it may
sorry.
be understanding that, because we might be missing something, and I don't want to totally rule it out without understanding if there's some pieces of information.
Yeah.
And did something happen at an agency in Litchfield? Did something happen over here that we're not all having access to that information? Was there a domestic violence situation in the nurse there? So maybe we should figure out, why is the list this long, and then try to get this list down. And then also for everyone to understand, it's not the end of knowing the risk, and like Karen and everyone else said, a button It helps us to know something's going on and you're not in this remote area alone. Great. But never to send a nurse in thinking you got that button, just press it
Yeah.
and we can save you. But I believe we can do it as a group. We just have to figure out the rationale and then move forward.
So I wasn't sure where you were going when you started, what you were saying when you started talking about the wound issues, ostomies, et cetera. To me, I was sitting here thinking, okay, this is typical DPH gotcha, because you could be certified, you know, a certified WOCN, or you could be a certified hospice nurse. You could be you could have passed the training that we suggested get developed at the state level, yet something happens, so we got you anyway. So that's where I thought you were going.
No,
Um,
no, I'm just saying
but
that we've been doing extra things in home care.
yeah,
We can do this too.
right. No, I agree. I agree. And I do think it's important for us to really look at this language and take out, I mean, diagnoses that have remained stable over time. Why is that even in there? I mean, that's part of our assessment has always been what are the diagnoses and what's exacerbated and what's not. We know that, you know. So the domestic abuse, um, you know, and the other piece about the fire, that was a not licensed home health or hospice. That was a live-in. And they're not even being considered in this situation. So maybe Barbara's suggestion about the standard training goes beyond home health and hospice. It
Yeah.
includes both, but it should go to home care providers.
Right, but if they're not licensed, you gotta find
You
another
can't
way
tie
to
it to, right, right.
because it shouldn't be those agencies either.
Yeah, yep. But they do have some required, well, some required trainings. So those are things that eventually, and that's something that as they move over to DPH, which they're going to be doing eventually, something that we can tie into that. Well, we're at 424. I have a couple of concerns. You know, I think we've come up with a few ideas for bringing forward. The next meeting with the large group isn't until 12/3, which is 2 weeks from today, right? Um, but the law states this about the work group. Um, it says, not later than January 1st, the working group shall submit a report on its findings and recommendations to the Public Health Committee. The working group shall terminate on the date that it submits such report or January 1st, 2025, whichever is later. So I think we're covered if I don't know if we have to formally ask for an extension if we feel we're not going to be ready. But if we rush and we submit this report and we don't feel as though we have adequately thought through all of our recommendations, the moment that report is submitted, we're done. So do we ask Anwar and McCarthy Vahi for an extension?
I'd say yes, especially because we're heading now into the holiday. We're not going to be all present all the time. I think it's worth going further into the new year.
I agree. And I think, part of the reason why this is so challenging is because the law was rushed. So
Oh,
Yeah.
good point, Jen.
we
Very
want to
good.
take our time and get it right.
I agree. I think you're right, Tracy. I think the law does give us flexibility with the time, the way it's written in that last sentence. But to do it justice, even based on this conversation, which I thought might be an hour, I thought, oh, we can come up with great ideas. But you start digging into this and you look at, how complex it is. So I really like the idea of just asking for some clarification. never hurts to ask. Because if we're gonna make, thoughtful recommendations that respect where this law came from, then it's a very valid thing for us to do, because I think you're right. We have to understand it to make sure we're not missing something. And while some of these ideas to us clinically might seem like, well, the diagnosis stable over time, you know, isn't that part of what we're doing? Why is
Yeah.
that written to this piece of legislation? I think it is important that we make sure we understand, so that when we look at, well, do we exclude or do we recommend that certain things be modified, that we're thoughtful and respectful of that.
And McCarthy Vahey gave us that opportunity at the beginning
Yes.
when we first met. She said that. She said this is a short time frame and we didn't get you together quickly. Do you want me to have a conversation with McCarthy Vahey, at least start with her because she's the one that brought it forward
I
and
think just
say,
out of respect for the process.
yeah. I will try to have that conversation with her before that next meeting so that, and even if, she wants to bring Senator Anwar into it for a discussion, however they want to do it. And then how do you want to proceed with what we're bringing forward to the full work group?
Think it would be good. We have a lot of experts on the full group, right? We have clinicians, we have ACT teams. They might actually help guide us along here with the clinical side of things and DOC. So I think for the next, on the 3rd, just like we're doing here, it's a moment for everyone to come forward, either with, just start out with hearing what they believe, maybe each break it down into each different group. So we had the home health team meet. I'd love to hear from DOC what their recommendations, the ACT teams, just to hear what they would have been recommending. And so we can have the opportunity to listen and also present what we found as the challenges and the barriers with coming up with solutions. But hearing and then coming together as a group to see if we're all at the same place with the same obstacles to even making a set decision, right? Or do we need more information from whoever created line 1 through 17 as far as why domestic, why? We might need to hear from that individual before we can move
I can
forward.
ask McCarthy Vahey when I talk to her too.
Okay. All right. So I'd love to hear from everyone else what their recommendations would be. Do we come up with questions based on where we're leaving this today to send it out there for them to think about?
I think we probably should.
Yeah.
Do you want you and me to, I mean, given the time, we're at the bottom of the 2 hours here. Do we, you and I kind of come up with a scripted questions to give them and have them think about and be ready to report out? I think we should open up the meeting saying we had this extensive discussion and these are the areas where we feel we want to see change and these are the areas that we really want to promote in the training and the check-ins.
Yeah.
Okay. Anybody else? Anything else?
Would we bring forward whatever we're recommending to as individuals for that meeting on the 3rd? So we can all answer the same questions that would be good. So we can still.
Yeah, you can. I think if anybody has, I guess in this group, if there's things that you want to bring forward, I'm strongly suggest best practices for our industries, but I don't suggest those being put in any kind of laws. So, if it's, I think that those are things that maybe a best practice or maybe a suggestion can be that, each agency should have a safety committee.
I like that.
I don't know. Each agency has to have a QAPI committee, based on your regulations. But maybe that's something as best practice. But again, I am very leery about putting anything in statute.
Mhm.
Unless it's
Agreed.
funding,
What?
unless it's funding.
Yeah.
Okay. Yeah, I think it's a great idea to hear from the other groups. They've heard from us. We've heard from them. We heard that they wouldn't walk into our situations, but they don't do what we do. And I think if we really want to try to continue to care for the individuals we have, and even if you look at this statistically on a really big scale, we've been doing a pretty good job.
Yeah.
With minimal incidents. Now, you never want to have one, right?
Right.
I think we all
Right.
agree, and it's saying that for the record. We never want to have one. However, we've done a pretty good job overall, historically, caring for people in the communities where we work and live. So I think, there's an added awareness that the tragedy brought and that this legislation was intended, I believe, to just make us, be more cautious and be more aware and try to break out of some of the history of, well, that's how we've always operated. That's what we're used to doing.
Mhm.
Now we got to be more situationally aware. We have to provide training. These are all important things. And if there's resources where we can do additional protections, great. Then we can institute those as well. I think it's unfair to just place this on home health and say, here's all these requirements. We're not going to tell you how to do it. We're not going to give you any training. We're going to penalize you when you get it wrong. And oh, by the way, there's one-time funding that expires in now 7 months. So
Yeah.
I think that those are unrealistic expectations on our industry when we've done really good. So let's hear what they have to say. Let's hear what the what they might recommend to us. They've heard from
Mhm.
us, and then I think I would like, to hear from senator and representative, if we're able to get some insight and clarity on intent, that would be really good. Or if they just, want to do that in some other venue with you, that's fine too. But I think that'd be an important piece of this process for us.
Okay. So Sasa and I will regroup and we'll get back to everybody and I'll reach out to CMV and see what she has to say, what she might be able to guide me on. And if she thinks that we need to meet with Anwar and her, then we can do it that way.
Sounds good.
Thank you.
guys.
Thank you.
Thank you, everybody.
Thank you.